An adult patient presents with progressive heel pain. I am showing you the lateral radiograph of the calcaneus. Describe the findings.
Okay, looking at the images. The radiograph demonstrates a well-defined radiolucent lesion within the body of the calcaneus. It has a narrow zone of transition, a very thin sclerotic border, and no associated periosteal reaction or cortical breakthrough. Centrally, within the lucency, there is a characteristic dense, rounded clump of calcification. The overall non-aggressive appearance, classic location, and central nidus of calcification are highly pathognomonic of an intraosseous lipoma.
What is the differential diagnosis for a well-defined lucent calcaneal lesion, and what are the classic imaging features of this pathology?
Okay. The differential diagnosis for a well-defined calcaneal lucency includes a unicameral bone cyst, post-traumatic pseudocyst, giant cell tumor, desmoplastic fibroma, and aneurysmal bone cyst. Calcaneal pseudocysts are normal anatomical variants that represent a paucity of trabeculae. Unlike these other lesions, an intraosseous lipoma is characterized by its central clump of calcification, which represents dystrophic calcification secondary to fat necrosis. On computed tomography or magnetic resonance imaging, the lesion will demonstrate fat attenuation or fat signal, confirming the diagnosis.
Describe the common anatomical locations of intraosseous lipomas and any systemic associations.
The calcaneus, specifically within the neutral triangle, is by far the most common location for an intraosseous lipoma. Other frequently affected skeletal sites include the proximal femur, tibia, humerus, pelvis, mandible, and vertebral bodies. When it arises in the long tubular bones, it is typically located within the metaphysis. Intraosseous lipomas can be found in patients of any age, show no gender predilection, and can sometimes be associated with systemic hyperlipoproteinemia.
Explain the histological components of an intraosseous lipoma and why these lesions can become painful.
Histologically, these lesions consist of mature adipose tissue interspersed with varying degrees of fibrous tissue, myxoid degeneration, bone trabeculae, and fat necrosis. The central calcification corresponds to areas of ischemic fat necrosis and subsequent dystrophic calcification. Although the majority of intraosseous lipomas are asymptomatic incidental findings, they can become painful due to expanding fat necrosis, intralesional hemorrhage, or microfractures in the surrounding thin trabeculae.
How would you manage this patient as a radiologist?
In that case, as a radiologist, I would recommend comparing this radiograph with any prior foot or ankle films to confirm lesion stability. If there is diagnostic uncertainty, I would recommend a non-contrast CT of the foot to confirm fat density attenuation within the lesion, or an MRI of the foot, which will demonstrate high T1 and T2 signal-matching subcutaneous fat that drops out on fat-suppressed sequences. I would document these benign features to prevent unnecessary biopsy. Finally, I would reassure the patient and refer them to a foot specialist for conservative management, as surgery is rarely required unless a pathological fracture is imminent.